I saw a peacock clock the other day and I thought about you. Are you still doing the
I
peacock?
promise you now.
Yeah.
You can't sit behind me.
I mean, I saw it was on Pinterest or something, but of course, every time I see him, I always think about you. I see my house and everywhere.
They're about to go live in a minute.
If they're about to go live, you know. This is crazy. I'm not saying. If they gonna personally call me, I can't.
Oh my God.
Miss Sharp.
Hey.
What's up? So guys, after we do the, after I do the introduction and introduce Mayor Pete, we're gonna go around and have everybody do a 30-second to a minute introduction.
What?
Yeah.
Oh
No.
I believe in all of it.
No, I'm telling them I didn't know.
Oh, oh.
I don't have to.
It doesn't have to be 30 seconds. You know, you can say, you know,
What's your name?
represent yourself.
do I have to come back to it? I just wait to call. I can do this. I wait to call. This is so great.
I don't do something good. I actually come behind the scenes.
Not prepared. What are you doing? What's she doing?
Look, I didn't tell the I thought you did.
But your questions are so much better.
What is your question? I need a question. I have.
Y'all have questions?
No, I don't.
Ask something about coronavirus.
No, because I don't want to hear his answer to that. Because I work in healthcare and I'll be upset. So that's my thing. My healthcare stance, I'm not familiar with it
Right.
at all. I'm the wrong one.
Be honest.
He just gave me permission.
We like honesty in our politics.
Yes,
What's up?
not on a panel. In the crowd.
You playing the role of office.
Let me go up and everybody.
What? What happened? I can't tell you, I'm not clinical, I'll tell you that.
I mean, you're just my person. I want to know, like, that's why I'm asking you.
I can't answer that. I'm not a clinical professional. You should probably ask one of them, and there's not one of them on the panel, which is unfortunate. So I wouldn't ask me that.
Well, I'm living in Congress out in the north. So, like,
Don't do that. You're gonna embarrass me. She reminds me of this guy from college. Something college. Went to Florida, you know.
What year did you graduate?
Undergrad. Oh wait.
Smile, you all scared? Cool. Oh, excuse me. I know a lot of folks that most of them graduated
Well,
with 6 or
I
6.
assume.
But it says play basketball, that was what I told him.
He didn't get lost. We're good.
Hello, how are you?
Take it away.
well, everyone, thank you for coming and welcome to our Health Equity Roundtable with Mayor Pete Buttigieg. I'd like to welcome everyone to Nicholtown Baptist Church, and we are so happy that all of you are here today. As we all know, leading up to Saturday's primary, that health equity and health care is a major issue throughout South Carolina, but predominantly in our African American communities. And we have gathered together an esteemed panel to come here today and discuss this with Mayor Pete Buttigieg and discuss his plans and his vision regarding health equity for the African American community if he and when he becomes president of the United States. So again, we're very thankful for you to be here. We are going to go around our panel and have everyone take 30 seconds to a minute to introduce themselves, who they are, what they do, and why they are here. So we would definitely like to start with the young lady at the end, and we will work our way around.
Hi, my name is Alicia Edmond. I am a 15-year healthcare professional. About 8 of those years have been a healthcare executive. I have lived in various areas of the country, and as I relocated here to Greenville, and this area is rural, and it's undergoing a lot of change. I have a strong interest as I build my family here and grow within my career here as to how the politics will affect the community that I will live and work in.
My name is Javertis Burnett. I am here on behalf of the community group. We are a community of young African American male professionals who give back into low-income communities by mentorship, and a lot of that focuses around healthcare initiatives as far as obesity, exercise, things of that nature. And so I'm super excited to have a seat at the table to see what's going to be done for our youth to make sure that we're able to have part in that healthcare equity that we're talking about and discussing today. Wonderful.
Well, happy Thursday, everybody. My name is Stephanie Priester, and I always like to say I'm the face and the voice out here in the community trying to help to educate our people, and I'm very excited to be a part of this health equality roundtable discussion to really bring some of those questions to the forefront that do affect us in our Black and brown communities. So I'm a radio personality. You know, people always ask me all the time what I do. I just say I do business, and so that's a plethora of different things. So I'm honored to be here today.
Hi, everyone. My name is Alicia Sullivan. I serve on the Lawrence City Council and chairman of the Lawrence County Democrat Party. Also a CEO of Sullivan Healthcare, which is a healthcare contracting service, specifically that contracts OT and PT in different healthcare facilities. And I'm here today as well to see how we could talk more about creating more health equity in the community.
Hello, I am Tracy Blue. I am the owner of Blue Realty and Associates, as well as co-owner of HSSC Home Care. I'm excited as well to be here as a small business owner and entrepreneur and health professional to be able to hear more specifically the things that you plan to address during this election.
Thank you.
Hey, good afternoon. My name is Jessica Sharp. I work at the YMCA, but I also have a consulting company where I work primarily with educators, and I teach folks about the impact of poverty and trauma on the brain. And I work with a variety of young people who are experiencing poverty and trauma, and so I'm excited to talk more about how we can support them.
Good afternoon. My name is Dr. Frank Clark. I am a psychiatrist who practices in Greenville, South Carolina. Excited to be here to advocate not only for our profession, but for also our patients, as mental health disparities are something that I see day in and day out. So thank you for being here.
Hi, my name is Caroline Caldwell, and I am the CEO and Executive Director of New Minds Health and Care, which is a behavioral health program that specifically deals with people who are returning from incarceration or families that have been affected by the criminal justice system. There are a lot of trauma. There's a lot of need for juvenile mental health. There's a lot of need for reentry mental health and behavior modification that is not covered by any expanded Medicaid. I am also the vice president of Upstate Pride, where I advocate for LGBTQ plus folks. We are two very marginalized populations that are in need of health equity. So I am very interested in seeing how the Douglas Plan will address those populations.
Everyone, we thank you for being here. My name is Jalen Elrod. I am the first vice chair of the Greenville County Democratic Party. Have the blessing of being here, able to moderate this great discussion. We would like for the mayor to open up with a few words and just want to get right into it. How about that?
Sounds good. All right. Well, thank you for moderating, and thanks to everybody for being part of this event, because I think this is a really excellent combination of insights and experiences to bring to bear. And I'll try to be fairly brief in presenting what we envision as part of the campaign, because I think this would also be a good opportunity to get a sense of your stories, those you serve, the priorities that you've seen emerge. And since we brought a few friends along with cameras, it's a chance, I think, very literally to shine a light on some of the struggles, but also some of the solutions that you have seen and that you have pursued. And my hope is that we'll be able to illuminate how different and better presidential leadership would be supportive of the work that you're doing. One of the themes that you'll see across all of our policy work, but especially when it comes to health equity, is the belief that not all of the answers have to come from Washington, but more of the funding should, because we see a lot of work that is happening at the local level or at the regional level where solutions are being developed, especially when it comes to health inequities, that need to have more of a wind at your back in the form of resources, but that we need to really tailor in a way that's going to make sense on the ground. And I was reviewing some of the statistics of the challenges that you all are dealing with specific to South Carolina, a state that has the 9th highest mortality rate for women, and that is something that we know here and also across the country is 3 times as likely to occur for black women as for white patients. Here in South Carolina is the 7th in the nation for adults with diabetes. And it is now the case that approximately 1 in 6 African Americans residing in the state are living with diabetes. We know from HIV/AIDS data that the majority of new diagnoses are in the African American community. And so many of these issues I know are very close to home here, as in different ways they've been close to home for us in the community that I served as mayor for 2 terms, a community where we saw the effects of violence and trauma and the need for care that is informed by understanding adverse childhood experiences, where a lot of these challenges of reentry were at stake. But where also there were a lot of creative solutions, like the partnership with 100 black men that had nurses in barbershops, finding men a little more willing there to, for example, be part of screening for diabetes than they were in a clinical environment. And these are exactly the kinds of local collaborations I think that we need to do a better job of supporting and funding at the federal level. So part of what we've proposed in the context of the Frederick Douglass Plan to dismantle the effects of systemic racial inequality in the country is a real focus on intentionally dismantling the health inequities. That means within the first 100 days, establishing a national health equity task force that will specifically map out where these inequities are sharpest. It also means creating and investing in what we're calling health equity zones. Again, this is an example of where that will be defined and decided by local partnerships, local government, nonprofits, community leaders, but should have federal funding to help design a strategy and then make sure that strategy can develop with support from the Department of Health and Human Services. I believe that we can act to end the HIV/AIDS epidemic by 2030, that we can tackle a diabetes epidemic that has been heading in the wrong direction in many ways, in many communities, and that we can end this crisis of maternal mortality in a country that is lagging behind almost all developed nations, especially for the experience of black and other minority women. We also need to make sure, excuse me, I have my own health moment here. We also need to make sure that we're investing in the profession. Part of what's driving, we know, the issues around health equity, things like the maternal mortality gap, is that there's often a lack of cultural competency. There is bias, explicit and implicit, in the system. And that means training our health workforce to be anti-racist and to combat these kinds of bias in the clinical environment. It also means simply recruiting and empowering more clinical professionals who come from the very communities that have been excluded. So when we talk in other areas of the Douglass Plan about things like investing in HBCUs, for example, it's not just out of a regard for HBCUs and the work that they do, but also out of the knowledge that a next generation of African American doctors, nurses, and researchers need to be supported so that we can close the disparities in who's represented among the decision makers and the practitioners, knowing that that built-in cultural competency will lead to better outcomes at the clinical level. I also think that we need to recognize that health is not only the job of the Department of Health and Human Services. That, for example, when we look at criminal justice reform and decarceration, that connects directly to health. And yet we have things like the Medicaid exclusion for those who are incarcerated, that especially for those dealing with substance abuse or mental health challenges, which is of course a huge population, a huge proportion of those who are incarcerated, that makes it that much harder to get continuity of care. When we're talking about housing, housing is inseparable from concerns of health. We saw it in our community, for example, with the challenge of lead poisoning. I'm pleased to say that the water is not the problem where I live. I was the mayor, I was in charge of the water. We saw to it that the water was good, but we had terrible problems with lead poisoning because of the houses themselves. And low-income families in older neighborhoods where houses were built before that 1978 ban on lead paint were the most likely to show up with high exposure to lead. These, of course, were also the neighborhoods where people were disproportionately redlined into. And so if we're talking about things like housing desegregation, that is also a public health issue. So my point is that there will need to be an Office of Health Equity and Justice, not only in Health and Human Services, but this needs to be in the considerations of DOJ. This needs to be in the considerations of HUD and every department that is working on things, that EPA, that ultimately reflect on public health. Coverage is important. I think that coverage has probably dominated the debate a little bit disproportionately, so I don't want to dwell on it too long. But I do believe it is necessary to ensure that everybody can get covered. That's the idea of the Medicare for All Who Want It strategy that we favor, that everybody would have access to a quality public plan. If it's low-income folks, then it will be subsidized so they don't pay anything out of pocket. As your income rises, we still make sure that it's never more than 8.5% of anybody's income to pay for the premiums to get on an excellent plan. And I believe that we need to establish monthly out-of-pocket caps on how much somebody can have to spend on prescription drugs. And the reason it's got to be monthly is, right now, even if you have insurance, a lot of times you have a yearly cap. and you see people delaying coverage or delaying filling in a prescription or getting a procedure so that they hit it in the right month, which makes no sense medically. And of course, most of us don't experience the economy on a yearly basis. The bills come in every month. So I think the out-of-pocket cap should be monthly too. Let me mention just a couple other things that I know are impacting South Carolinians in particular and need to be addressed through an equity lens. One is, again, environmental justice. So 56% of African American residents in South Carolina are in the same census tract as a Superfund site. This points to the need, first of all, to increase the funding to clean up Superfund sites, but also to look at how housing segregation has played a role in sending families into areas where they're made vulnerable to health issues simply by where they live. And then you layer on issues of contamination with things like food deserts, even exercise deserts, right? If there's not a place where a parent knows they can take a child to play that is safe, this too is a question of public health. The other thing I would point to is the need to support small water utilities. I know what the community of Denmark has been up against, and not the only one, where there haven't been the resources for lower income communities to be certain of access to clean, safe drinking water. And so I'm proposing, as part of our $1 trillion vision for infrastructure investment, that there be a dedicated fund for supporting communities that are trying to enhance their water infrastructure to deal with these issues. So I could go on, but I'm going to stop here because hopefully that gives you a flavor for the kinds of interventions that I believe that we can undertake. And it's all based on this philosophy that we've got to start thinking about politics and government first and foremost in terms of how it affects everyday life. And the biggest impacts on everyday life are for those who have often been most directly excluded by policy in the past, and now's our chance to get it right. So having laid down some of those markers, I'm very eager to get into a conversation and learn more about what is impacting the people you serve, answer any questions I can about our vision, and gather any input on how we could make it more tailored than ever to the work that you're doing.
I like the eagerness. What I was going to say was, of everyone on the panel, I probably have the least amount of healthcare background, so I'm really interested to hear how the conversation is going to go and to learn what everyone has to say, to really hear about everyone's experiences and hear their questions. And since you seem very eager to ask the first one, we're definitely going to throw it to you first.
Well, I mean, I thought about it because for a few years I served as a marketing director for New Horizon Family Health Services, which is a federally qualified community health service center, along with Lipogenesis Healthcare that's in Spartanburg. I mean, we talk about, making these the Medicare for all that would want it, but my concern would really be we can make it available for them. We can even make it free. But them having access to get there is a concern. And so I really want to know how can that piece kind of intertwine with the plan for the Medicare for all, or even if it's free hair. I mean, how can we, even for you being a president, say that this could be inclusive with making sure if we're going to have this available for them, how do we ensure that they can get there to make those appointments?
It's a great point. There's so much sizzle in the debate around getting everybody insured, and we got to make sure everybody's insured. But what good does it do you to be insured if you can't get to a provider? Right. If you don't have the transportation to travel to a provider, or if the providers in your area are closing. And so whether we're talking about the federally qualified health centers, which are doing such a remarkable job, but are clearly under-resourced, whether we're talking about the closure of rural facilities. By the way, one thing that the majority of rural facilities that have closed have in common is it's in states that refuse to fully expand Medicaid. So it's something that deserves to be raised at a time when you got a president who I think claims to be caring about rural America, and we're not really seeing that. The provider shortage, I think, well, there's two things. So there's a shortage of providers, and then there's this transportation issue. The provider shortage, I think, is why it's not enough to just create Medicare for all who want it. We've also got to set reimbursement rates that encourage people to go into underserved areas and encourage people to go into areas of practice where there's not enough people to do it. And in particular, I think that's true of mental health, where we are seeing. And by the way, another great thing about the FQHCs is they have done often a remarkable job of having primary care and mental health care right alongside each other. And it's not just about physically locating them next to each other, but that sure helps when you're trying to integrate them. But I also believe that health funding has to include transportation funding, because we have to make it possible for people to actually access what they need. And so part of the funding we're proposing in rural health in particular is to address that issue. Otherwise, you're right, you might be insured, but it doesn't mean anything if you're not able to actually get the care.
So, Mayor Pete, I would, piggybacking off of Stephanie's question, you know, one of the things that we argue being a part of the community group, and even in my personal, just daily professional life, like I work with a lot of physicians, I work with a lot of medical professionals. And one of the things that I think we don't talk about enough in our communities is that a lot of the issues aren't, you know, you mentioned, you know, prison reentry. We got a high population of prison entry, diabetes, all of these things. But at the end of the day, I think all of these issues come back to economic.
Yes.
And they're economic on two ends. They're economic on one end. When you think about the New Horizons and the Regenesis, like I volunteered with both of those organizations. When you think about those organizations, the caregivers there, the physicians there, the people that are serving there are forced to say, hey, if I want to do good in my community, I have to make half of what my contemporaries are making in a larger facility, in a larger hospital space. So that's financial on one side. On the other side, we do have the transportation issues. We got so when you talk about healthcare equity, like, what does that really mean, and how do we get to the bottom line issue from my perspective of there being a real economic and financial gap that's causing this disparity? Because, and it's on both sides from a provider standpoint, and as I'm sure you've heard a ton of it, a lot of people think that your plan will quote unquote cripple the healthcare system, so to speak, or get us to this place where we've got like one governmental healthcare system. Like, how do we combat that? What's your kind of response to that?
I think you're right. You know, one of the things I've found, especially when we're talking about racial inequities everywhere from criminal justice to health, is it comes back to economic empowerment too. And so to the first side of the coin you're talking about, the side of those who go into the profession, it's one of the reasons why I believe we need to true up these reimbursement rates and have a system that can tell the difference if you're providing for an underserved community. I also think that when we redo public service loan forgiveness, we should do it with this in mind. So there's this program now, Public Service Loan Forgiveness Program. Great idea. You work in public service, you get your student loans forgiven. But almost impossible to take advantage of. Most of the loans don't qualify. You got to do 10 years straight before you get any benefit at all. So what I would do is make it more user-friendly, more generous, and have a bigger sense of what counts as public service. If you're a mental health provider to an underserved community, I consider that public service whether you're technically in the public sector or not. And I think that should qualify. So that's the first side of the coin you're talking about. The other is the biggest issue of all, right? And I think we can learn a lot from the Black Economic Alliance framework of work, wages, and wealth. And you'll see that reflected in a lot of what's in the Douglas plan on the economic side. It's everything from big business, making sure that when we're talking about fund management, for example, for pension funds overseen with federal oversight, where billions of dollars are moving, can more of that be in minority-owned business? All the way through to the medium-sized enterprise, where I'm proposing we set a 25% goal for federal purchasing to reflect the communities that have been underserved, or you might say underestimated, in terms of their ability to do business with the federal government. All the way through to recognizing that, okay, that's great, but not everybody's going to go start a business. So just the basics of wages. What could be worse for your health than poverty? And raising the minimum wage, for example. Extending access to union rights to categories that have been historically excluded, whether we're talking about domestic workers, direct care workers, which we're going to need a lot more of as the population is aging, gig workers. As far as I'm concerned, if you're doing a gig, you're doing work, that makes you a worker, and you ought to have labor protections. Fast food workers. We're in Charleston marching with workers there trying to get 15 in a union there. And we've got to make sure, and we know this disproportionately affects Black and other minority workers. So all through the spectrum, we've got to be intentional about this. And the way I explain this to majority audiences is that this is not about doing anybody a favor. This is about fixing something that was broken on purpose and won't be fixed without intention. Because if you save $1, that compounds over time, right? On into your descendants and through the generations. So if that's true of the value of a dollar that is saved, then that's true of the value of a dollar that is stolen. And what we are seeing today in health outcomes is the effect of generational theft that has to be put right. And that's why we have to have not just intentions, but dollars going into remedying it.
So,
Yes, ma'am.
I have a question.
Yeah.
So I'm going to piggyback again off of the access that Stephanie has stated. And although your thought process, I guess, is to increase the reimbursement and to the monthly cap, for hospitals, doctor's offices, medical facilities that are not in a rural area, how will you help us with maintaining the quality, right? Yeah. And knowing that access is a huge portion of how we get paid in our reimbursements now, right? So how is that going to affect us in that aspect while maintaining the quality? And then I'd also like to get a better understanding of currently clinical providers within the area, especially within the state. There's a lack of diversity in them, right? But the patient panel within Greenville is high minority. Right. How do you plan to help build that cultural competence? Because most of the providers who are teaching our up-and-coming students now are teaching from their current education state and not with how we would want them to treat our true population for the quality we want. And they may have some biases. Yeah. You know, so how do we attack that's currently happening within our area?
Yeah, so I've got some thoughts, and I'd welcome other ideas you might have too. But part of it, I think, is, and this reaches back to the first half of your question too, in a way, is how do we train the next generation of providers, right? The only way, if we're going to increase reimbursements and maintain quality, then we're going to have to be investing in expanding the profession. That means making sure that we invest in more institutions being certified and qualified to train more professionals. And means making sure that whether it's through Title II or whether it's through these offices of health, equity, and justice that I'm proposing, that it's done with a specific intent toward greater representation of racial minorities. The question of how bias gets passed down, I think, is a really important one. And I think it's become even more urgent now as technology plays more of a role, because the other question is how bias tends to get automated. And there's a lot of evidence that without intention, in other words, without being intentional about reversing bias, the more things get automated, the more it can perpetuate those biases. I'll give you a simple example that was explained to me recently that I think is revealing. If you go into Google Translate and you type in the sentence, she is a doctor, he is a nurse, and you translate it into Turkish, which doesn't have any gender pronouns, and then you open up a new window and you start it in Turkish and you translate it back into English, it comes back, he is a doctor, she is a nurse. At least it used to. And it's not because some sexist programmer at Google was saying, only men ought to be doctors. It's because the algorithm inhaled whatever bias was out there in just language across the internet, and then reproduced it. And so when we think about the different factors that could be contributing to either detection gaps or inadequate service for black patients in clinical environments on everything from mental health to maternal health, right? Can we use those same technologies to actually identify and expose the biases? And because part of what we also have to do, I think, is in a way that doesn't arouse the defensiveness that will happen when people who are established in a certain profession are forced to call into question a certain way of doing things. We need to be able to gather a body of evidence about how these biases are happening. And I think that's exactly the kind of work the federal government should be leading, because we can create those kinds of data that you can't argue with, that can then inform a different kind of training. In addition to making sure that the next generation of clinical staff are just plain more diverse themselves. That's where we've got to partner with HBCUs. We've got to partner with training programs to look at the ways where underrepresentation of staff almost automatically means that there will be continued lack of cultural competency. But again, those are some of the things we think we can get a handle on. If there are other things that you've seen that worked, we'll be eager to hear about that too.
Mayor Pete, 2020. So I work with two marginalized populations. I work with people who've been previously incarcerated, and I work with the LGBTQ plus community. And I'm going to speak to equity in both of those instances. With people who've been previously incarcerated, there is little to no medical health care provided. There is little to no mental health care provided. So when these men and women are coming out, and let's understand that 65% of the incarcerated population are brown people. So when they're coming out to these communities, they are coming out with diabetes and no medication, hypertension and no medication. I'll tell you about a client whose family was in my office yesterday, lost his leg while in prison to diabetes because of a lack of medication while in prison. And he is being released with no wheelchair and no prosthetic. And so that's what we're doing to our citizens and to our human beings. So when you talk about a lack of health equity, we're talking far beyond what I think we really consider is there. We have a mental health system here in South Carolina that is completely stressed. I would want to say in the last 3 months, I know they just merged all of our centers, but there was a 6-month waiting list to see a psychiatrist. That's insane. And that kind of change, even though it's on a state level, doesn't happen unless there are policies and legislation that cause a different flow. So as my president, how will you address that issue, Mayor Pete?
Yeah. I mean, that's where we've got to look to the federal government to set a floor. And what you're describing, I think, would be characterized in the international environment as a human rights violation.
Absolutely.
Right? And when we're talking about the state assuming responsibility for somebody while incarcerated, there is a responsibility to make sure something like that can't happen, let alone making sure when we have returning citizens that we are lifting them up and making it possible for them to integrate and contribute as they would seek to do. This is why, again, things like the Medicaid exclusion while incarcerated, I believe, have to end. And you're right, then you have people who are living at the intersection of different vulnerabilities. LGBTQ plus people of color who are also incarcerated are among the most vulnerable people. And that means we have to have intention and policy specificity around how they're going to be supported, given the health needs we know they as a population face. These kinds of delays you're describing for mental health care are something we're seeing all across the country. And often, especially when we're talking about substance use disorder, someone's life depends on whether somebody can see them in relatively short order. And so in addition to dealing with a provider shortage, I think we need to create ultimately a rights framework and a liability framework that establishes a responsibility for making sure nobody can fall through the cracks. And the younger people are, the more we see these vulnerabilities really surface. And so if we really want to break the school to prison pipeline, for example, this is a good example of where somewhere in between the education side of it and the criminal legal system side of it is the health nexus. Because a lot of times this is about disability, it's about mental health, it's about trauma. And we have to bring that perspective to bear on what's going on. Because the other two systems, frankly, without a health perspective, are going to be incapable of handling it. And so what I envision is a rights framework that sets the floor, but also a partnership with the organizations that are serving those who are in such need to make sure that the resources are going toward, for example, in order to meet the goal that I've laid out of decarcerating the country by half, we will be solving one problem, which is that we are far too incarcerated, but creating a new pressure, which will be more returning citizens. And that means we will be doing a disservice to everybody if we're not prepared for that.
Absolutely.
And we can't do that with public sector agencies alone. We will have to make sure that the funding is flowing and that the technical assistance is there so that the organizations that are already set up to do this kind of work can scale and expand when we really need it.
Guys, I hate to be the bearer of bad news. Ms. Caldwell had to be our last question for this panel. Would definitely want to say, though, we want to thank all of our panelists for coming here today and really shining a light on this issue of health equity, especially among our African-American communities. Definitely want to thank Mayor Pete Buttigieg for coming. For those of you who don't know, you are in the Nicholtown community. And Nicholtown is one of our historically African-American neighborhoods that we have here in the city of Greenville that has been neglected in myriad ways. So the fact that we can have this discussion at Nicholtown Baptist Church in this community and really give voice to the plight of those who live here, those who are still ensnared in poverty, those who are being gentrified out of their community. Gentrification is a huge issue here in Greenville it's very heartening to know that someone who is running for the highest office in the land would come here and continue to speak out about their plans and their vision for bettering this community. So we definitely want to thank you for coming. I want to thank all of our panelists for coming in. We definitely wanted to see if the mayor had any final words that he wanted to give.
Great. Well, again, I want to thank everyone who's participated here. And since we always hit up against time when we're sitting down, we hope we can remain in contact with you through Jalen or through our campaign staff to make sure we're continuing to gather ideas and respond to questions too. I know that you are living the things that presidential candidates talk about all the time. And so we want to make sure that we are a resource to you, but also just as importantly that your experience informs what we have to say in the policy space. Because sometimes we talk about whether it's economic issues or health issues. Sometimes I find they're being talked about like they're the result of these cosmic, impersonal forces out there, when really they're the result of decisions that were made in white buildings in Washington, D.C. And I believe if we make different decisions, we will experience different outcomes. And so much depends on us connecting the decisions that are made there to the lived experience of the people who you are serving and who this campaign seeks to benefit. And so I'm looking forward to continuing the dialogue as we go on. And I'm very thankful for your time, for your participation, and for your work.
Thank you.
Thank you, everyone, so much.
Thanks so much. Wonderful. Thank you. Same here. Thanks, Mark. Thanks for the support. Thank you. All right. Absolutely.
Thank you so much.
Be mad at me because I didn't take a good picture. So I just want, I mean, really. Yeah. I'm a good man, you know, yeah.
I'm just trying to, I don't want a picture from this thing, so I'm just trying to get it.
Oh, honey, it's such a thing.
Already there. I'll see you.
Wait, give me a second.
Okay.
Mayor Pete, can we have a few words? Mayor Pete, can we have a few words over here?
What's